confirm that he may be here for a while.
Uh,
Mark, are we recording? Let me see if there's any communication about it.
There, it is recording. You can see the top half left of the screen where it says record and has a red button next to it. It's recording.
Okay, fantastic. And if anybody has my cell phone number, don't text me because it'll hear it. Perfect. So case one, this was a call dispatched as a choking. The original call by dispatch was to go to an address outside, not the current or actual address, and it was actually billed as a pediatric patient. So there was a little bit of confusion from the documentation, sounding like the EMS crews had gone to a house down the street, but they were flagged down by the friend of this patient. So when they arrived, they found a 28-year-old male who appeared to be altered in having respiratory distress. Documentation for PPE was appropriate, and they documented that they limited non-essentials such as the friend to the cold zone to ensure that the least amount of people were affected or exposed. Primary survey for this patient included that he was essentially altered and not able to respond to any questions regarding orientation. He looked like he might have had some type of obstruction or his respirations were inadequate, secondary to him gasping on the ground, and that there was no evidence of any active hemorrhage. So essentially, the primary survey was mostly concerning for airway. Vital signs that they documented from initial contact are, as you see, he's not tachycardic. No blood pressure was recorded. His respiratory rate was recorded as 14, but his SpO2 was 68%. Past medical history was limited. Sounds like the friend didn't know much history about this gentleman, and later on during the encounter, the father showed up, and it sounded like he wasn't too helpful as he wasn't on scene when this incident occurred. And then how I set up my QAs is that I try to give you guys a timeline from everything that's documented. And the first underlined time is patient contact. The second underlined time you'll see in the timeline is when we leave the scene. So it gives you an idea of time course. And this is how I actually review these cases. So initial presentation, this patient is lying on the floor prone, gasping for air, and they note that there's water on the floor mixed with some of his blood, but no active continued bleeding. They also note that there's some meat on the countertop. And then as they move on, after the first patient minute of contact, they start chest compressions, trying to free what they think is an airway obstruction and place them on a non-rebreather mask. They get actually the first set of vital signs is about 4 minutes after patient contact, which I'd already reported to you guys. They noted that in their narrative, there wasn't a time frame, so I will just talk about it. So they get access on this patient. The time course might be a little bit off to those that actually were on the scene, but they get access on him. They get him on oxygen. They note that his response to oxygen goes from 68% to 91%, and they attempt 2 times to try to clear his obstruction with a laryngoscope handle and McGill blade to try to remove it without the patient further decompensating. But unfortunately, the patient is too hypoxic and altered, even though they have him on his side to try to ensure that if he does vomit, that he doesn't aspirate it. He keeps on pulling away despite these measures. So the crew elected at this point that he had a partial airway obstruction that was soon to be a full airway obstruction, and with inadequate respirations, that they would go ahead and RSI him. So they started with etomidate 30 milligrams, followed by succinylcholine. They noted that they were able to pre-oxygenate him to near 100%. They do have some difficulty with intubation needing a second attempt. And actually, what they documented was that they saw the large piece of meat in some secretions. And so they remove the blade, grab the suction, and clear out the secretions and also remove the foreign body. So on the second attempt, they were able to place the ET tube. They note that his initial end tidal is markedly elevated at 74%, and they confirm his tube placement with the other measures besides end tidal. They follow up with spinal precautions, and they sedate him before they get into transport with 5 of Versed and 50 micrograms of fentanyl. They leave the scene at 15:17 and notify the hospital of their arrival. They were able to get another set of vital signs, which you see improvement in his end-tidal CO2. And I believe that there was an error in the SpO2 recording, but as you can see in the next set of vital signs 10 minutes later, that he is not satting at 10%, and that his heart rate has improved with his interventions as well as his sedation. And they arrive at the hospital, looks like about 18 minutes after they left the scene. So as for the QA discussion, for those of you that have received follow-up from me or feedback from me, I try to write it as a paragraph noting the things that trying to be as detailed as possible about the documentation and care. But this is kind of a summarized version on this lecture. So the good things that they did on this call was their assessment, their treatment. They were able to which oftentimes is the case, perform appropriately despite limited information. And they did not tunnel down just on his airway obstruction. They were able to recognize that the patient may have sustained a spinal injury, with presuming that he had fallen and there was blood on the floor. They initially attempted to free his airway obstruction with the McGills and the laryngoscope, but after 2 attempts, they decided to escalate to a higher measure to gain airway access and obstruction removal. And their RSI dosing was appropriate for the weight of the patient that they documented, as well as tube confirmation in the use of continuous end-tidal CO2. They were able to continue on with his C-spine management and his sedation and dosing frequency. And then areas where we can improve is, as I mentioned earlier, is have suction ready so that when you place the blade in past the lips or the teeth, that's considered an attempt, to have all your measures ready at the same time so that you don't have to take out the laryngoscope unless it's absolutely necessary. Or if you can clear out suctioning beforehand. But as we all know, once we place the ET tube or the laryngoscope or the King Vision or whatever measures we're using, it may become more clear deeper down in the airway that there's secretions that need to be removed. And then to use a bougie. And then the last point was that overall, I thought that they did a great job on this critically ill peri-arrest gentleman. So he arrived to the hospital. They got a chest x-ray to confirm tube depth, and they documented some RSI and some sedation meds that don't appear to be what was actually given. So an error in what they heard, and the importance of how we need to document our medications more than just the name of them, but also the dose. In the emergency room, they did image him. They got CT images of his head, facial bones, cervical spine, and thoracic spine, as well as a chest CT. All of those were negative for any acute processes or evidence of fracture. And his initial labs were concerning, which probably were significantly lower with EMS arrival, but after resuscitation, he was still acidotic at 7.2, and his alcohol level was 0.205, so he was intoxicated. During his hospital admission, he was extubated on the following day, and he was discharged on hospital day 2 with full neurological recovery. So I thought this would be a great opportunity to talk about foreign body airway obstructions, what to do if this crew couldn't clear his obstruction, or if there was any kind of complications or errors or issues going forward. And then also if there was any questions about should they have done abdominal thrusts or should they have done chest compressions? What's the best way, and has anybody looked into that? So the data shows that foreign body airway obstructions are the 4th leading cause of unintentional death. That choking etiology for pediatrics is usually food, although there are non-food items such as coins, balloons that also make up a large percentage of these presentations. And in adults, food and medications are the most common, as well as non-food items and emesis. Conditions that should increase our suspicion for foreign body airway obstruction are going to be our patients with Alzheimer's, Parkinson's, if they've had any previous strokes due to dysphagia from those strokes, any psychotropic meds that cause them to be subdued or I guess you could say subdued or altered, any developmental or intellectual disabilities, alcohol intoxication, poor dentition, or advanced age. And then I looked a little bit into the data about chest thrusts, abdominal thrusts, back blows or slaps. In pediatrics, back blows and slaps are definitely recommended, with the head of the patient being the most dependent, allowing gravity to work for you. Obviously, our adult patients were not able to pick them up and put their head down towards the ground. So they say that there's some data that shows that chest thrusts are more efficacious to clearing an obstruction, but there's not a lot of data that says one is better than the other. And what I found in my literature search is that if you find that one isn't working for you, if like for this case, if they were trying to do chest thrusts and then they weren't able to clear the airway nor visualize the obstruction, then to alternate between chest and abdominal thrusts to try to improve your odds, as one of these usually will work if you use it in continuous alternating fashion, or it just doesn't work. So going over our Southwest region protocols, just seeing if we also did meet the protocol criteria for airway obstruction, I would say that I would lean on this being more of a complete obstruction, as the patient is unable to talk, he's nearly unresponsive, that they recommend AHA protocol as well as laryngoscopy to see if you can remove that foreign body with the McGills, in that if the obstruction is not removed and unable to be ventilated, that you can consider a crike unless they're a child. So what I would like to add is that the crike is, this image here shows you where the cricothyroid membrane is. It's actually below the vocal cords. So the crike would be indicated if it's a foreign body above the vocal cords, as you would be able to ventilate below. But if you can't see the obstruction when you're using laryngoscopy, the chances are that it's probably going to be below the vocal cords. So it's probably unlikely for the crike to be successful. In that, if that's the case, then I think that, and Lynn can speak to this otherwise, but if you can't see it when you're looking inside the mouth with a laryngoscope, I think that the best option for us would be to go ahead and attempt to intubate and push down the foreign body in hopes that it would go down, not get stuck at the carina, and would be more likely to be a right main stem, and then ensuring ventilation to the left lung until they're able to clear that obstruction. Lynn, do you have anything to say about that?
Yeah, that's an unfortunate kind of way to do that, but that you really can't get into it any other way. I mean, if you can't see it, you can't see it.
Yeah.
You probably want to try to see if a bougie could get down into it but you'd probably want to go and get a fairly small Well, actually, probably a fairly medium-sized, probably a correct-sized ET tube and just push.
Hmm. And I will tell you, in my residency, they had a pediatric case that a toddler had come in with a respiratory distress and had actually had choked or swallowed partially, which turned out to be aspirated a balloon, one of those kind of like animal balloons that the clowns use. And when the kid got progressively worse, that's when it became clear that it was an aspiration. And when they were trying to remove that balloon, it was no longer visualized above the vocal cords and had gone down deeper. The kid arrested, and the balloon was actually stuck at the carina, obstructing both the bronchi.
Yeah, I hate those clowns.
All right. So let me see if anyone has any questions after, because I think that's the last of this case. Yeah. So I'll make a quick look. Doesn't look like it. All right, moving on. Case 2. EMS was dispatched to an unresponsive party. The information that they get is that this is a 51-year-old male who's unconscious and unresponsive. PPE was taken before patient contact. And so I'd say in the HPI down here is delayed in access. So the team did document that there was a delay in access as the patient was out, I believe, on a park field or a baseball field, so a little bit away from where they had parked, and then they had to move his body in order to appropriately manage him. So primary survey, the patient's unresponsive. It may be hard to see, but the U is bolded for the future slides. His airway's open, but it's inadequate, and there's no evidence of active bleeding. Initial vital signs documented with a SpO2 of 60%. The crew does not document a heart rate or a respiratory rate, but they do state that the patient was pulseless and apneic, which I think is a good opportunity to put 0 in those two fields. Past medical history is unknown, as the son does not know of any himself. And then the history goes that he was playing catch with his son. My understanding is that his son was either like a teenager or an adult, not like a little kid, when suddenly he collapsed and became unresponsive. 911 was initiated immediately, and then bystander CPR was started. They project that his downtime was less than 10 minutes upon EMS arrival. So patient contact started at 12:55. He had CPR already being performed. They checked pulses and resumed CPR. They noted that he was in a Shockwell rhythm, which was VFib, and resumed CPR after shocking him. They were able to get IO access. Checked on the next pulse check. He was still in VFib. They shocked him again. They got him 1 milligram of epi after the second shock. On the third pulse check, he was still in VFib, so they shocked him again. They followed that with either 150 milligrams of amio or 300. The transporting ambulance and the fire department medical record conflicts. I'm not sure which dosing that he got. And on the next pulse check, he's still in VFib, so they shock him again. They give him another dose of epi. On the next pulse check, he's still in VFib. They shock him again. On the sixth pulse check, he is in VFib again. They shock him, and he goes into VTAC with pulses. VTAC, and I believe it's a little bit unclear, but I think it was with pulses. And I know it's a little bit difficult in this situation virtually to be able to interject. But if we were in a classroom setting, I would offer I would never call anybody out specifically to talk about their case, but if you were on the call, you can clarify if I'm misrepresenting any of the information. And then they were able to get Rosk back subsequently at 13:13 with the vital signs that are listed here, not tachycardic, not hypotensive, and still altered. They start transport at 13:15. They notify the hospital of a cardiac arrest alert, and they get a post-Rosk 12 lead. They repeat his vital signs and arrive at the hospital. They state that they weren't able to place an oral pharyngeal airway because he had a gag. They also note that when with good CPR, he was semi-conscious and somewhat combative, and with agonal respirations, in that they did attempt an ET tube, but that was unsuccessful, so they placed an iGel. And I didn't have times for that, so that's why it's on the right side.
Jackie, did on that at 1308
Mhm.
VTAC VFib to VTAC,
Yeah, and
then he's at SVT.
1322.
But what happened? What happened? The VTAC spontaneously resolved and went to a SVT or what?
Well, I'm gonna show you. I think that's a great question. It's a little bit unclear, but what is clear is the tracing. So I think
Okay.
that the tracing will help. So this, as you guys can see, is chaotic, disorganized, representative of ventricular fibrillation. So this was shock at 200. So that was the first shock. So this is the first rhythm. And then this is shock 5, another disorganized rhythm. And it looks like he goes in from VFib to what appears to be somewhat of an organized rhythm. I am more inclined to call this wide complex, although their 12 lead calls this narrow complex. I think that you could call this maybe, his rate's 144, maybe AFib with an aberrancy or AFib with some kind of other conduction delay, but given that he's in cardiac arrest, he's not young, that it probably odds are that it's ventricular in origin. I don't call myself an electrophysiologist or a cardiologist, so I'm willing to discuss other interpretations of this as well.
Yeah, well, this looks like an AFib with with aberrant conduction to me. I mean, it's grossly irregular. It'd be nice to have an actual rhythm strip
Mm-hmm.
rather than a full 12 lead, but that's that would be my inclination to think of this coming. To me, this is clearly not VTAC.
I think that yeah, I mean, I don't know. I feel like that, there were many cardiologists will potentially have different opinions that they wouldn't agree amongst themselves, but I think that's where the difference is that it was documented from VFib to this above rhythm to being organized and potentially VTAC. And then with the 12 lead interpretation, I think that's where the SVT recording or report on the electronic medical record for EMS come from. If there's no other questions, we'll move on to the QA discussion. So the parts that I thought they did good, or they did well with, was that they were quickly able to assess him, identify his rhythm, shock him, all done within the first 3 minutes of patient contact. And it sounds like even in their documentation, they had to move him away from the fence. So pretty remarkable for the amount of assessment and care in 3 minutes. They were diligent on continued efforts with ACLS and defibrillation with a total of 6 shocks for this patient. They didn't miss the opportunity to be thorough by checking his glucose. They did get a 12 lead ROSC EKG, and they decided to hold. Their rationale for holding for intubation was due to COVID risk and exposure for trying to do direct laryngoscopy, in that they felt that their BLS in between measures, the supraglottic airway was managing his ventilations adequately, and that there was no need to put themselves at unnecessary risk, which I think is great. And that areas for room for improvement. Now, I believe that there'll be some differences even between us on this call or on this lecture, but the consideration for magnesium plus or minus lidocaine in sustained ventricular arrhythmia, considering reposition of defibrillator pads, which I'll talk about in the next few slides, clarification on discrepancy in amiodarone dosing. I wouldn't have put this in here for room for improvement if a dose was 300. So because dose was documented by the transporting crew as 150, that's why I'm even mentioning it here. And then documenting vital signs, even if they are 0 or absent, so that there is no room for misinterpretation of what that patient had. And it's also just good patient care and documentation. And then overall, I thought that their quick and persistent actions led to this patient getting ROSC, and then a little bit of a spoiler alert of full neurological recovery.
I would say that there's one other thing that I would see on this one is that they've got I'm reasonably confident that they gave 300 milligrams of amiodarone to start with, but I wonder why they did not give a second dose of amiodarone if they had persistent VTAC or a VFib. I don't see any evidence of torsades here, so.
Yeah. No, that's accurate. Yep. So case follow-up. In the emergency room, he was noted to be following commands but had continued facial cyanosis. They thought that even though he appeared to be purposeful, that he needed further airway protection, and given his projected hospital course, they RSI'd him. They did give him 150 milligrams of amiodarone bolus followed by a drip, and he sustained another cardiac arrest where he went into ventricular tachycardia. He was shocked at 200 joules and converted. Cardiology was consulted, and they took him to the cath lab. Fortunately for him, or unfortunately, depending on how you look at it, he had no significant obstructive lesions, therefore no stents were placed, and that they attributed his arrest to ischemic cardiomyopathy. In further discussion, I don't know if this was with the family member or with the patient following extubation, he had recent anginal symptoms. And then as for the hospital course, he was cooled. He was extubated on hospital day 1. He did have a complete neurological recovery. And according to the notes, the patient was pretty frustrated and wanted to go home, but they wouldn't put the ICD in until his COVID screen came back negative. That time, this was early, this might have been even March, that it was, I think, 3 to 5 days of him waiting in the hospital, hoping to get that screen negative, get the ICD, and go home, which he ultimately did. All right, any questions? I'll just wait till the end. So this just a picture representing an ICD. And that got me to thinking about, they shocked him 6 times. It's not, I mean, there's cases where a patient is in pulseless VTAC or VFib where they're shocking multiple times. And what are the other options besides CPR and shocking? And is there any chance to improve his odds of converting to a perfusing rhythm other than converting to asystole? So we're going to talk a little bit about ventricular storm or electrical storm, as well as refractory ventricular arrhythmia, which are 2 separate entities. So ventricular storm, it's 3 or more sustained episodes of VTAC or VFib or appropriate shock from an ICD in a 24-hour period. So what that means is that this patient, although there's controversy in who you speak with regarding the difference between ventricular storm and refractory ventricular arrhythmia, but ventricular storm is strictly supposed to be representing shockal rhythm with a regain in normal pulses in a 24-hour period of time. So this patient would be more under the refractory ventricular arrhythmia category. So this is a little different, but I think worth talking about. So it can occur with an acute myocardial infarction, structural heart disease, ICD, or inherited rhythmic syndrome, such as like Brugado or channelopathies. It usually has a poor outcome, 7.4-fold higher risk of death than patients without electrical storm that just go into a shockable rhythm and then they convert and don't go back into it. And then ventricular fibrillation that manifests as electrical storm has a mortality rate of 85 to 97%, as it's likely related to ischemia. In that we do see ventricular storm in patients that have ICDs, Usually, or I should say in the past, these patients would not have an ICD and they would arrest and not have it witnessed or early quick access to 911 or defibrillation. So a lot of these patients would not survive their electrical storm. But with the placement of ICDs, that these patients have a longer lifespan, in that even with an ICD in place, they may be shocked appropriately multiple times in a 24-hour period. So with the ventricular storm, it's important if you can identify a reversible cause, although it's a very small subset, usually less than 10%. And the table on the right here talks about what these reversible causes are. So if you shock them out of VF or VTAC, and you can get a post-12 lead ROSC or post-conversion 12 lead. If they have evidence of ischemia, that they would need a cath lab. If they have evidence of electrolyte imbalances, such as hypokalemia with U waves, or even potential, they also mention hypomagnesemia, decompensated heart failure, which you wouldn't necessarily see in a 12 lead, but clinically you would be able to suspect it. If there's evidence of like an elevated catecholamine, such as like hyperthyroidism, infections, or that is medication related. And then I mentioned ICD here because there's 3 categories if they do have an ICD, and then the appropriate shocking is the only one that's actually considered under ventricular storm. Inappropriate shocking is that it's shocking a rhythm that is not a shockable rhythm, so that does not fall into ventricular storm. That falls into ICD failure or phantom shocks, which is also not VF or ventricular storm. All right, so ventricular storm management, good ACLS protocols and adherence is going to be your mainstay, as well as airway management, IV access. Amiodarone has a 40% effectiveness with controlling ventricular arrhythmias in the first 24-hour period. Magnesium might be, if you either know or you think of the potential for the reversible causes, you can give them magnesium empirically. And then lidocaine, the research shows, is not as effective, especially if the ventricular arrhythmia is related to a previous MI or SCAR related, that lidocaine will likely not convert them. And then I mentioned ICD functioning normally as a previous slide, and then defibrillation pad placement. How it's been described to me is that everyone's heart doesn't lie in our chest quite the same way, and that if you're shocking somebody, which really I think is going to be more pertinent to the refractory ventricular arrhythmias, but the point of the matter is that if you're shocking somebody and it's not converting them, they might have a anatomical variant of the way that their heart lies in their chest, and they recommend either placing them in the alternate defibrillator pad placement or moving the pads just a little bit in either direction of where you already have it to ensure that you're getting adequate conversion and uptake of the joules that are being distributed. And then they do note that ventricular storm seems to be a vicious cycle of that you have a catecholamine surge. They go into this not shockable rhythm. There's more ischemia. We treat it with epi. There's more catecholamines if they are awake during this episode, or if they wake up after getting shocked, that it's a very painful experience. It's very anxiety and provoking, which releases more catecholamines, and that the mainstay is that if you are shocking somebody, that you're getting them, basically awake and aware of the situation, to be kind and give them analgesia to try to decrease the catecholamine release and surge. So the consideration is to give ketamine as opposed to any of our narcotics because of both the pain relieving portion and also the mild sedating portion. But I would say that if you're considering that, you're looking at pain dosing, which according to our protocol is the second line to fentanyl. So this patient fell more under the refractory VTAC condition. So this is continuous ventricular arrhythmia and never goes back to sinus rhythm. Besides good ACLS management, the options that you have really for this patient is going to be changing the defibrillator placement, either going anterior posterior or the typical, like in position 2, or the typical position 1 if you started the other way. And consideration for dual external defibrillator, I personally think that there needs to be more research in this to make sure that this is actually, one, it's not recommended by AHA, American Heart, and 2, there is discussion about with damage to our defibrillators, voiding of our warranties, that the manufacturers don't recommend it. I did look a little bit into some of the data which was published talking about dual external defibrillator, the difference between sequential versus simultaneous, stating that simultaneous is pretty hard to actually do, and that they do think that there's a theoretical benefit of doing sequential dual external defibrillator. But if you're even going to consider that it has to be the identical model and the identical defibrillator, and that those pads do not touch each other, but this is something that I don't think we should be pursuing at this point without further knowledge. So reviewing our Southwest protocols for this patient and ensuring that they did indeed do everything that was guided with our protocols. It looks like other than what Lynn had already mentioned, that the patient could have had another dose of 150 of amiodarone, the consideration for magnesium. It does say here that if amiodarone is contraindicated, that you can use lidocaine. I'm not in person to ask this question, but before I give you the answer, I ask you, do you know what the contraindications for amiodarone is in our protocol? So there's none in cardiac arrest. The only one would be at long QT because of torsades, and that would be not cardiac arrest. And then another theoretical or another contraindication, but not in our protocol, is hyperthyroidism, because amiodarone can cause that to be exacerbated. And then the only other thing on our protocol here that might be something to consider is sodium bicarb. Sodium bicarb, as it says here on the right-hand side of your screen, is not recommended for the routine cardiac arrest sequence. But I think that if you're thinking that this might be hyperkalemia, this is a dialysis patient who has not gone to dialysis, or that is known to be having issues with their potassium for other reasons, or if you think this is a potential overdose, that it could potentially be helpful, especially since if they're still in a VFib or VTAC pulseless, that they're in arrest, and there's nothing that really can make it worse than that. Although I should be cautious about saying that. There's always something worse. Any questions? It doesn't look like there's any questions about case 2. So moving on. Case 3, EMS was dispatched to cardiac arrest. This is a 43-year-old female, chief complaint unconscious and unresponsive. PPE, the information I was given did not talk about PPE in their documentation, although I suspect that they probably had it on. Primary survey, the patient was unresponsive. Airway was open or patent, but she was apneic. Breast sounds were clear to auscultation per the crew documentation, and there was no evidence of active bleeding. Vital signs, none were documented, but the narrative says that the patient's pulseless and apneic. Past medical history includes coronary artery disease with a stent placed and high blood pressure, high cholesterol. And then the history provided by family was that she was witness to collapse on the floor in the bedroom. They assessed her. She was pulseless and apneic. They started CPR immediately. And the family also reported that, she's been having some fainting episodes and that she was evaluated for that and had recently seen a cardiologist. They gave her this little adhesive device, which turned out to be a portable telemetry device. They document that they got on scene at 23:44, started high-quality CPR, and in their documentation, they wrote that they changed compressors at each pulse check. They placed her on defibrillator pads. 2 minutes afterwards, they placed an OPA. They were ventilating her with oxygen. At 23:47, they checked her rhythm. I think this was their first rhythm check, and she was in VFib. They shocked her at 200, resumed CPR. They were able to get an IO, and I'm not sure if, now that I'm looking at this, at 23:47, they shocked her again. Maybe that was accurate on how they documented it, but they shocked her again at 300 joules. At 23:49, they gave her a milligram of epi. It looks like at 23:54, between 23:49 and 23:54, she had regained pulses, but I'm not sure if that was right at 54 or not, 23:54. You can see that they document a heart rate, no blood pressure, no respiratory rate documented, 100% SATs and a blood glucose at that time. At midnight, they document a new heart rate and a new SpO2, as well as an end-tidal CO2. I'm going to scoot over to the right on the screen here. They talk about attempting to intubate her ×2 with King Vision, but were unable to get proper views of her vocal cords, so they turned that in for placement of an iGel instead, and then they confirmed the iGel placement. They noted that once she got Ross back, that she had some spontaneous breathing. They transported her at midnight 08, and they were able to get a 12 lead for her. At that point, they repeated another set of vital signs where they have a heart rate, a blood pressure, no respiratory rate documented, and SpO2 and end-tidal CO2, and they arrive at the hospital. So this is the first rhythm check. You can see on the left-hand side the disorganized, chaotic rhythm, interpreting as ventricular fibrillation. And then the second one on the bottom, also interpreting as VFib and defibrillating her. I don't see times on that, so I can't confirm if both these were done in succession as documented in the timeline. This is her ROSC EKG. Narrow complex, regular, and it looks like sinus, with some ischemic changes in her inferior leads with T-wave inversion, and maybe some elevation in her anterior leads. So care here, I thought, was great in regards to documentation of what they did. Their electronic medical record requires them to be really heavy in the narrative. So I thought that instead of looking at that as a hardship, they did a lot of documentation. Times and procedures were hard to follow based off of their EMR, or at least not able to be as concise. And I thought their airway and breathing management was great. They aggressively managed her with BLS until they were able to get a rhythm identified and meds on board, and then they switched to attempting to intubate her. They spent time in documenting, which I would have to translate to that they made it a priority to get back on her chest as quickly as possible with rhythm checks or any stopping of CPR. They identified a rhythm and shocked her. They escalated her defibrillation joules, in that they recognized that her endotracheal tube placement was difficult, so they, instead of continuing to try, they went on to manage her airway with a supraglottic airway. They confirmed it. They got a 12 lead, and they did monitor continuously on end-tidal CO2. Where I think that we could do better is that early administration of epinephrine opens up the options for her for antiarrhythmics such as amiodarone, and documenting, it's not listed here, but documenting vital signs even if they are 0 or absent. And then another spoiler alert is that she had a full neurological recovery, which was pretty amazing. According to the data nationally in 2019, that came out in 2019 last year, that only 8% of these patients will have a full neurological recovery. And I believe our data locally that we were just discussing with our CARES data is that locally, countywide, we're 10% with good neurological recovery. Is that correct in my remembering of the data?
Actually, our overall survival rate from cardiac arrest is around 19%, 18 to 19%, and of those, and 95% of those have a good neurologic recovery. Now, if you're looking at VFib as the presenting rhythm, we're at 40. Mark can correct me. I think we're at 45% this year, and literally all of those have gone out neurologically intact as a 1 or 2. So that's, like
Great.
you say, pretty damn good.
Really awesome. That's awesome, and that really speaks to quick access, great CPR, and identification of shockal rhythms and early defib. So for her case follow-up in the emergency room, she was intubated and she sustained another VFib-VTAC arrest 30 minutes after her arrival. She was shocked at 100 joules and she was given 1 milligram of epi. She did get ROSC back. They gave her 150 milligrams of amiodarone drip, and they did place a central line and an art line because she required vasopressors for hypotension. In the hospital, she did get cooled, or she was cooled. She arrested again, and they were able to get ROSC back on her after 15 minutes of aggressive ACLS. They took her to get a cath. I think it was the day number 2. They showed no significant occlusions. On day number 3, she had an ICD placed. She did have an echocardiogram that showed significant cardiomyopathy. And to remind you guys, she was 43 years old. So significantly low ejection fraction at 25%. And one of the other things that you may not have remembered, as I apologize if I give you guys any dizziness as I flip back again, that her past medical history is that she had a stent when she was 33. So pretty bad genetics or bad risk factors for cardiac disease to have her first MI at 33, cardiac arrest at 43. And she was discharged on hospital day 6 with a full neurological recovery. I did look at her chart, as they mentioned that she was recently evaluated for syncope, and she was actually within a month of her arrest. I think it was actually 2 weeks before her arrest, and that they had got a 12 lead, they did telemetry, they did labs, and ultimately sent her home with all intensive purposes, a external loop recorder or a monitoring device for her, and it did not pick up any abnormal readings between the time she was in the emergency room to the time she arrested. And she did return after she was discharged from this cardiac arrest for pre-syncope, understandably concerned that this might be an early sign of another bad incident to occur. So she was admitted just based off of her recent history, and then they discharged her with a diagnosis of hypotension related to dehydration or vasovagal event. All right, so that made me think a little bit about syncope and how we see a lot of it and how do we pick up the ones that are really concerning. I think for EMS side of things that, we really should highly recommend everybody to be evaluated in that this is more of an issue if a patient refuses to come to the hospital or like when they're in the emergency room and we're trying to decide, do they go home or do they stay? But I think that there's definitely some good information in the next following slides for all of us. So I don't know if the local community calls it fell out, but that was one of the hard things when I started working as a paramedic, to realize that when they would describe being falling out, that they were actually saying that they had passed out. They just didn't know our medical terminology. So it's a transient loss of consciousness and postural tone due to inadequate cerebral perfusion with a return to baseline function. It occurs about 2.8 cases in every 1,000 individuals annually, in that there's a lot of different causes. For us, the cardiac cause and the true neurological causes are the ones associated with the highest risk for mortality. So a lot of times they never figure out why the person passed out, as well as reflex mediated. Maybe they were urinating, maybe they were getting blood drawn, orthostatic, cardiac, neuropsych, or other drug use. So cardiac induced syncope, this can be related to any kind of dysarrhythmia, something that is not allowing for proper ejection fraction and decreased blood pressure and perfusion to the brain overall. It could be from structural heart disease like heart failure, previous MI with scar tissue, valvular issues that the patient may have, such as aortic stenosis, pulmonary hypertension. This could be from those people that don't wear their sleep apnea machines, or if they have underlying sarcoidosis, or if they have a PE. You would be not that surprised if you looked back at a lot of the data about a lot of patients that present with PEs, that they come in with something as simple as, hey, I was getting up from bed last night, and I passed out walking to the bathroom, and we kind of think, oh, maybe they're just orthostatic, and a surprising amount of those patients are actually have a massive PE or a pretty significant PE. As well as cardiac causes of syncope are associated with the highest risk of death. So these are the ones that when we hear about syncope, and especially really for our patients that are refusing transport, if we have a high suspicion for cardiac syncope, that I really think that this is someone that we need to call base and get base contact to try to convince them as well. So how can we predict who is going to have a bad outcome in the near future? Age is one of the strongest predictors of death. Elderly have a 1.3% associated mortality with just a single episode. Male is also non-preferred over female when it comes to syncope and potential for death. And then cardiac is the most frequent cause of death in children that have syncope. I will say something a little personal for that last bullet point. My brother passed away from a congenital cardiac problem, and the only thing that he presented with was syncope, unprovoked. He communicated with a healthcare provider who told him that he was just having a vasovagal episode and not knowing he was a year and a half younger than me, so I was like 8. And his second presentation was shortness of breath, and they told him that he had cardiac asthma, and it could just be bad luck, but just having some bad advice. But either way, don't minimize young people, kids that syncope, because it could be it's a very real possibility for it to be cardiac and etiology, and that they may be able, if intervened early, be able to survive that cardiac issue. So talking a little bit about the incidence and prognosis of syncope, this comes from the Framingham study. It's a heart study that looked at data from 7,814 participants for, I believe it was 17 years, and they evaluated the incident and specific causes and prognosis of syncope. Of those just under 8,000 patients, 822 reported syncopal episodes. And then looking at that data, they noted that cardiac syncope doubled their risk of death. Neurological syncope, their risk of death was increased by 50%. Syncope of unknown cause was risk of death was increased by 30%, and vasovagal had no increase in risk of death. So the vasovagal episodes or the reflex mediated that was mentioned to be about 40% of the cause of most of the time usually doesn't have any relation to risk of death, but it's those smaller numbers, that idiopathic, cardiac, and neuro, that we really need to be heightened awareness on. So in summary, high risk categories for syncope is anybody that has an abnormal 12 lead. So if your patient had a syncopal episode, a 12 lead should be obtained, even if they're refusing, and obviously convincing them that, can we just get this 12 lead, that there usually is no charge from the other agencies I've been associated with if we're not transporting. So you can tell them that they won't incur a bill for us to get this 12 lead. It's just a little bit more data for them. Suspected heart disease, heart failure history, if they're short of breath, if they're hypotensive, even if it was intermittent type, like a one isolated hypotensive event, family history of sudden death, or that they're an older patient that's male specifically, or male being higher risk as well. So looking back at our 43-year-old female, suspected heart disease is probably the only thing that she may have had that put her at a high risk category, based off of her initial presentation for syncope in the emergency room prior to her cardiac arrest. So looking at our protocols, could our crew have done anything differently? If they were, actually, I was looking at just basically a hypotension or syncope. I don't believe that, from what I saw in the ER documentation, she came by private vehicle. But if she had gone, she contacted 911 initially. Would there be anything that that you would, I guess, need to consider or to do if you don't normally do so, just to revisit our syncope protocols? Looks like, get IV access. I think sometimes I don't know about it necessarily here because I haven't been here long enough, but in some of my other agencies that I've worked with, that they don't always get IV access. So make sure you get access on them. If they need a bolus, they're dehydrated, they have abnormal vital signs, consider giving them some fluids, make sure they're on the monitor, and get a 12 lead. And then in our protocol, it also talks about who our high-risk patients are, which was mentioned in the previous slides. All right, any questions on case 3? Looks like VF, just like Lynn had said, Mark had wrote that VF has a 45% resuscitation rate, and that with a good neurological recovery, and that 19% overall for all comers. Case 4, dispatch to a diabetic unconscious party. Information provided was a 61-year-old male, unresponsive. Per assessment with EMS, he was responsive to painful stimuli and maybe had some abnormal decorticate posturing. They took appropriate PPE. Primary surveys, this patient is responsive only to painful stimuli. His airway is open, but he's not protecting. He has no active bleeding. Vital signs recorded are only an SpO2, no documentation of heart rate, blood pressure, or respiratory rate. And past medical history is diabetes. His wife states that when she left for work in the morning, he was fine, but when she got back from work, he was found on the floor, and as they had found him, and that she thought that it might be his blood glucose. They get on scene at 17:22. They note that the patient has some spontaneous eye movement and that his pupils are unequal. And they assess his alertness. At a few minutes later, they put him in C-spine precautions. They note that his room air sat's 96%. They leave the scene 10 minutes after initial patient contact. While they're transporting the patient, they're pre-oxygenating him with 10 liters. Not certain, it looks like from our protocols that it should be 15 liters, and it may be 10 liters because of some concern about COVID and aerosolization, but it wasn't documented for why the 10 liters as opposed to 15. And they state that while they're pre-oxygenating him, he started to vomit. So they tried to suction him, but his mouth wouldn't open. There was some rigidity or stiffness. They put him on the monitor. They get a line on him, and then they do attempt to repeat his vital signs with a respiratory rate and a end tidal at this point. No heart rate or blood pressure. It looks like they don't get a full set of vital signs until 1739, so that's about 17 minutes from initial patient contact. They suction him and they prepare for RSI. They give him ketamine followed by succinylcholine, and they intubate him on his first attempt, and there is no full set of vital signs again before hospital arrival. They do document that a blood glucose was obtained in their narrative, and I have to hope that they got that early on because I don't see it documented in the time frame until after they, where was it? Trying to see where they documented in the not able to see in my time frame when they documented the blood glucose, but it was after quite a bit of time from their initial assessment, and it's something that we do want to get a blood glucose early on, especially in a diabetic, in the event that we don't have to call a stroke alert, that it's not just a hypoglycemic patient. They document that they were having difficulty in getting a blood pressure on scene, and that they do acknowledge that he was tachypnic with deep respirations, but if a blood pressure is not attainable, do obtain the count on the respiratory rate and record that in your documentation. And then they document that they did a video laryngoscopy, but and that they were able to grade on doing video, and then they were able to visualize appropriate anatomy to place the tube. So this is just a end-tidal CO2 waveform. Looks to be as expected with ventilation and not apnea or pause between ventilations. And then QA discussion. Things that they did great on this case was evaluating for reversible causes. I have to assume, and I know what they say about assuming, that they did get a blood glucose early on, one, because they were concerned of possible differentials besides stroke, and two, the wife on scene had told them that she wanted to make sure his blood glucose was okay. So I'm assuming that the documentation on the procedures is just not accurate based off of when they actually checked it. That they assessed his neuros, noted that he had some decorticate posturing. They did take C-spine precautions. They had the proper indications to perform RSI. He was altered. He wasn't protecting his airway. He was vomiting. They did pre-oxygenate him, maybe under pre-oxygenated, but they did get his SATs up. They did appropriate dosing for RSI. They did appropriate tube confirmation with direct visualization and continuous end-tidal CO2. Where they could improve, besides the pre-oxygenation liters per minute, is documenting vital signs. Kind of the theme in all of these is that we need to be sure that we are documenting what we check, even if they're absent and not present. Use a bougie. There was no documentation that a bougie was used for this, so that's what why I'm mentioning it here. And then make sure if we're using any of these devices, such as a BVM, that a HEPA filter can be placed, that we document that it was used in our narrative or our cases. And then repeat vital signs after intervention to ensure that they've actually had effect or had no effect on the patient's hemodynamics. So I don't really, case follow-up. So in the emergency room, the time, of course, that the paramedics got was that she saw him last in the morning when she left for work. When the doc called the wife, she now tells the doc that she had spoke to him at 2 o'clock that afternoon and that he was fine at that time. And as you can see, that they initially got patient contact at 5:22. So he calls Neuro 911. They do a stroke alert with the most aggressive measures because of the short time frame. They get a CT scan of his head, and note that he has a massive intracranial hemorrhage. Neurosurgery was contacted, and they reviewed the images and said that his injuries were non-survivable, non-interventionable, and that they thought that it was related to untreated or undermanaged hypertension. So the family was contacted, and they decided to make, in light of this information, to make him comfort measures only. So he was extubated in the emergency room, admitted, and passed away on hospital day number 1. And then the next image here is the CT scan. I created a video for you guys to look at to give you an idea of, think of that patient's presentation, how profound his neuro exam was and his presentation, and think of the size of this intracranial hemorrhage. So to give you guys an idea of what you're looking at, this hard to see delineated is going to be bone, but we're looking more, so this window is set for brain. This represents normal brain tissue. As we run the video, white, especially in this region here, represents bleed or blood. And there's also midline shift, this being the midline, and you can see that your ventricles are pushed from left to right. All right. That comes to the end of this presentation from me. Does anyone have any questions? Thank you for your attention. If you were able to learn anything that will help in your practice, that is even better.
We'd appreciate any feedback on this too. Just type it in before you sign out, and we'll keep it open for a couple of minutes. And we're going to try to continue. If you like this, we're going to try to continue this kind of format. We may even continue it on a monthly basis as its own standalone educational piece in the middle of the week, or the middle of the month, or the end of the month, however it works.
Yeah. All right. Well, thank you guys again for your time, and if it's helpful, let us know so that we can provide this more frequently for you guys. All right, I'm going to stop sharing. And
yeah, that works. Thanks, Jackie. I thought that went very, very well.
Awesome.
So far.
Cool. Yeah, let me know what we can do better for the next time. So.
All right, groovy. Well, in the absence of any questions, I'm just gonna shut this whole thing down.
Cool. And then I think, are you Mark, are you going to send me these communication in the chat and I can respond to these people individually?